Carpal tunnel syndrome, subacute and chronic. In carpal tunnel syndrome, with a more chronic presentation, there's going to be fascial restrictions that will occur in the forearm flexors and the forearm extensors. So we can start to work with some of our fascial techniques in order to reduce these restrictions. We can work on an indirect fascial glide by providing a bit of stretch to the tissue and then engaging the fascia, the fat, and the skin, separating our hands away from each other until we feel the point of resistance, waiting for 90 seconds or longer until we feel a release or creep to the tissue. Our direct fascial techniques can be applied with our palmar surface by engaging just proximal to the tendons of the flexor digitorum and superficialis, and engaging the fascia, the fat, the skin, and the musculature below, providing an increase to muscle extensibility, decrease in pain, decrease in trigger point activation. Depending on the client, you can use a skin rolling technique depending on how accessible the tissue is to pick up and do a skin roll. You may find it's more restrictive, so you might want to create a stretch of a certain restricted area using a C-bow with the web space of one hand and the fingers of another, or using an S-bow. 3 to 5 minutes of a direct technique will help to facilitate more muscle extensibility. You can alternate between the fascial techniques. Keeping in mind skin rolling is more aggressive, and if it's uncomfortable for your client, you may want to go back to indirect or your glides. Fascial restrictions in the flexor retinacula will occur, so we want to be stretching these areas as well. Keeping in mind, in an acute stage where there is a lot of inflammation, you would not be incorporating these techniques. In a more chronic state where inflammation has been decreased, you can start to work a little bit deeper within the retinacula. So you can do a fascial glide with your thumbs being direct and a glide, or you can support the area using your elbow and coming in, engaging that tissue and that retinacula and going for a glide to increase extensibility. Careful to stay off the carpal tunnel so that you're not applying pressure into the area where you have a lot of pain. Crossed thumb spread, waiting for 90 seconds, and a creep to the tissue. Following our fascial techniques on the flexors, we could do fascial techniques on our extensors as well. Because joint range of motion would have been impeded, we can mobilize our radiocarpal joints both anteriorly and posteriorly to increase flexion and extension. To do this, we would support our client's wrist on a bolster, isolating at the distal end between the styloid process of the radial and the ulna, and then taking my distal hand over top of the first row of carpals and doing a grade 1 distraction and a posterior glide to a grade 3 with our intent to be to stretch holding 8 to 10 seconds, releasing and repeating 2 to 3 times. And to increase the opposite direction, a grade 1 distraction, and then an anterior glide. To increase wrist extension, a grade 1, a grade 2, grade 3, sustained, holding for 8 to 10 seconds, coming back to a grade 2, back into a grade 3, and again repeating 2 to 3 times. So this position is going to stretch the posterior scalene. If I want to stretch the middle scalene, I'm going to take it into true lateral flexion to the opposite side. And to stretch my anterior scalene, I'm going to take it into lateral flexion and rotate to the same side. Holding each stretch for 30 seconds. Carpal tunnel syndrome, subacute and chronic. Oftentimes, scalenes will develop trigger points. So to treat the trigger points on the scalenes, after we've done our neuromuscular warm-up to the area, going to palpate, looking for a jump sign or a recreation of symptoms as indicated by my client. Once I've located the trigger point, I'm going to apply ischemic compressions for 20 seconds to a minute until I feel a release of the trigger point or your client indicates to you that there's a decrease in symptoms. Following the trigger point release, going to flush the area and stretch. Stretching the scalenes, I'm going to take the head over to the side and rotate to the opposite side. Going to hold the stretch for 30 seconds. And I'm going to apply some moist heat to the area. Carpal tunnel syndrome, subacute. When working with carpal tunnel syndrome, we want to have our client in an elevated position to help us with lymphatic drainage. So we've applied some hydrotherapy, some cold hydrotherapy onto our client's hand and wrist. We want to make sure that it's nice and stable and that the hydrotherapy fits the condition. If our client has a decrease in sensation, we want to use cool rather than ice cold. So we want to keep that in mind when we're treating carpal tunnel syndrome. So our first treatment modality that we're going to incorporate is lymphatic drainage. So we will clear our terminus at the cervical region, and we will apply 30 pumps, which is a light superficial stroke to stimulate our lymphatic system. And then we'll pump our axillary lymph nodes. And just taking our client out and pumping for 30 pumps. Then we're going to continue with our wave-like motions. 5 to 7 pumps in an area, either bilaterally or unilaterally with one of our hands using our web space. 5 to 7 pumps per area from proximal to distal. When we get towards the wrist where our inflammation is the greatest, in a subacute stage, we can use our shaving with the back or side of our finger, which is nice and light. And we would finish by clearing our terminus and the cervical region with another 30 pumps.